Good afternoon, everyone. I'm Coralie. Sorry. I'm very pleased to welcome you to this closing panel. More seriously, it's the last session of this conference of 2 days. I have the great pleasure to welcome again Albert Al Friedman. Where is he? Oh, okay. So Al, a psychologist, you know him. It's my pleasure also to welcome Malin Castleton, if I pronounce it well, Malin. So Malin is a Swedish patient living with Sjögren and representing the Swedish League Against Rheumatism. Please, if you want to take a seat as well. Please also welcome Tuğba Konturk. I hope I pronounce it well. One of our partners from the industry. And massive thank you to Geoffrey Urbanski, who will join us for this panel because Chiara Baldini left early, and Geoffrey really kindly offered to accept to be our clinician today. So, setting the scene, the gap we face, because how do we bridge the gap from awareness to action? We have identified all the gaps, all the unmet needs that we are still suffering. Now, concretely, what are we doing? So from awareness to action. Dr. Urbanski, Geoffrey, let me start with you. From your clinical perspective after these days, what do you see as the most urgent gap between awareness and action in the care of people with Sjögren?
Thank you, Coralie. To take a relapsing joke, in case you doubt of it, I'm not Chiara Baldini. If it was not obvious. How much time do I have?
Let's say, I don't know. We'll see. Go ahead. I would like to hear all of you, let's say, during 10 minutes, the four of you.
Okay, can be brief. Just two perspectives. I would start with the clinician one, because it's not the most important, I do think. Yours I will tell later. From our clinical perspective, as a, I would say, specialists, I don't like the word experts, we need to inform our students about the existence of Sjögren disease. I started to work on that a long time ago, and at that time it was not even taught during the medical school studies. It was at the bottom of the list. So we talked a lot about lupus, and sometimes about scleroderma, myopathies, but Sjögren was at the end of the list. So I tried, at least in my university, to change that and to say, okay, we cannot skip the Sjögren disease because it's probably the most frequent that you will face. And whatever you do, orthopedics, rheumatology, pathologist, whatever, you will meet patients with this disease. While on the other side, for some rare forms of myopathy, you can spend hours to teach that, but probably they won't meet any patients with that in their life. So we have a huge effort to do to teach that, and we need to change minds, because even at that time, I'm still facing colleagues saying, oh, you know, it's just about depressed women with dryness. That's the thing I heard even recently, and I really don't like this. I got enemies because of that, so sometimes I said, you're saying that just because you don't know. You don't know how to do. People told me recently, oh, you know, the lip biopsies are completely useless because you won't do anything after. And I was saying, you said that because you just don't know how to do that. And I think we need to do huge effort to bring this disease in the forefront of the medical studies in our areas. So this is our work to do, because if people knows, they will know how to think about it and to whom to refer the patients. So this is the clinical perspective. The patient's perspective, you are on the good way. For example, I'm very happy that you changed the name from syndrome to disease. It sounds nothing, but I remember a long time ago asking, when I was a student, to Eric Achula, a very famous immunologist in France, but why are we talking about syndrome in Sjögren? Because there is a rationale of physiopathology, so it's a disease. He said to me, we don't really know, it's the term for a long, long time, and no one thought to change it. So that's a huge progress, because it means there is something that gathers the symptoms, the physiopathology, the patients by themselves. And the main task I think you have to do is to pressurize the authorities, the health authorities, the administrative authorities. I will give you a brief example. So I submitted the paper I talked to you yesterday to very brilliant and famous journals. The main answer I received is, it's amazing, the samples are amazing, the study is amazing, but it's about Sjögren, so we won't take it. This was the response for Nature, Science, Cell, and I talked about that with Xavier Mariette, and he said to me, I think you're right, there is a glass ceiling in Sjögren. We don't know why. If you are talking about lupus, you will go to those journals. But Sjögren disease is not really well considered. So I invite you to continue, because the time has changed and the patients have much more power to pressurize everything you can. Probably, as it has been done in the US with Venus Williams, having someone on the social aspects leading the thing, because it helped them a lot. You know, we have a social society where there's a social pressure, and it's good also to have like a mascot somewhere to say, okay, we represent something, because it's important to have leading voices, as you have here. But it's on your side this way. We are, as physicians, doing the main we can, but the ball is in your side too.
Thank you, Geoffrey. We will take this advice very seriously, and we will continue to advocate to payers, regulators, and maybe some more influent reviewers, and we will spread our wings again and again. Malin, you live with Sjögren's every day. What does this gap mean for you today in daily life? What is your major gap as a patient?
Well, as a patient, first of all, I would like to just say thank you for addressing the knowledge gap, because it took me 5 years to get diagnosed. I saw an eye doctor the very first year, and he suspected Sjögren's. He took a blood test. I didn't have the SSA antibodies, and he told me, you don't have Sjögren's. Do you hear that? Yeah. And it would take another 5 years and a major crash where I couldn't get out of bed anymore. And then this journey to a diagnosis took several months where I was unable to function, or because it was missed to start with. And I think that the knowledge gap, I'm so glad that you're advocating for education, because we have to be aware that many times and certainly what's the case for me, it's the primary care physician who is tasked with identifying Sjögren's. And in a sense, it doesn't matter if we have brilliant biomarkers, if we have brilliant treatments, holistic care, if the doctors who are tasked with identifying this disease are unable to do so based on clinical symptoms. And today we have fatigue, that's very non-specific. We have dryness, could also be due to many other factors, and it's most often not Sjögren's. And pain, it's very, very non-specific, and I think we need to work on tools to help those physicians out, to actually, so that their suspicion is raised, if you will, based on clinical symptoms, because that's when they will do the testing. Obviously, for me, this gap between needs and living with Sjögren's every day, for me, I say, like, I've gone from Malin, 51, to Margaret, 83 years old. I need to rest a lot. I can't live my life to the full. It's frustrating, but you learn to move beyond. But that's really what the gap is all about now. I think also going back to the time it takes to get a diagnosis, I think if we can reduce that time, it would reduce a lot of trauma in that period of time when you are dismissed, you don't know what's going on. It's very traumatic. If we could reduce that time, I think it's easier to move beyond later on, to reduce the trauma.
Thank you, Malin. Trauma is a very, very hard word. So, thank you for that. Tugba, from the pharmaceutical perspective, how do you see your role in helping to close this gap, as many gaps we do have, whether in research, in access to treatment, or just collaboration with the community?
Thank you, Coralie, and thank you, Malin, for sharing your journey with us. So I think we shouldn't first see ourselves as a separate stakeholder from the other stakeholders, including the patient community. At the end of the day, we are, or can be even, patients, caregivers, and loved one walking the same journey. So we are connected to each other. In that light, I see our role more than developing medicine, but always truly trying to understand and address the real lived burden and experience that each patient faces every day in their daily life. So through collaboration, like my friend Trent, Maria explained, in Sjögren Europe, and many other patient advocacy groups in the countries. So we have heard loud and clear what the real pain is. It's not only impacting their physical health, but also their work, their relationships, their social interactions, intimacy, and mental well-being. So flares are definitely not just abstract clinical events, but they're emotionally charged moments that bring pain, fatigue, and dryness together in ways that can completely reshape someone's day, week, life. So not minor inconveniences for sure, and they're life-changing realities. We should accept that, and we have a responsibility as the industry to listen and to respond. So we need to build research frameworks that really capture what truly matters to each patient. That can mean like energy, sleep, clarity of mind, and emotional strength.
Sorry. Thank you, Tugba. I think we are working closely together, yes. And I think it will really be fruitful very soon. You talk about emotional. Al, I'm going to you, of course, emotional. Awareness is not often about medical facts and symptoms only, but what about the psychological support and emotional realities now? What makes it, again, so hard to transform awareness into real support for patients, and what can we do as patient association?
Well, first, I understand the theme of this session is from awareness to action. My first instinct when I thought about this is that I think it's important for us to acknowledge that awareness is, in fact, a form of action. It's a form of support. It's the first step. And in terms of mental health and emotional health, just using this group as an example, I understand this group is 6 years old, which means that 7 years ago, a patient in Europe who was diagnosed with Sjogren's, this wouldn't be here. This wasn't here 7 years ago. So now this group is here. And the fact that you're here gives patients who are newly diagnosed support immediately. There's nothing worse than being diagnosed with a rare disease and having nobody know what it is and having nowhere to go. So these days you get on the internet and people tell me every day who are newly diagnosed, I found this group and it gave me hope. So that awareness is a significant first step and an important first step. We talked earlier about the systemic challenges that get in the way of more substantive action, including the invisibility of the symptoms of Sjogren's, the stigma associated with seeking mental health treatment, the lack of integration within the healthcare system between medical disciplines, much less with mental health professionals. We're viewed as a separate entity in a separate system in the United States, and that doesn't work very well. So these are the systemic challenges. On the patient side of things, we have to remind ourselves, and you patients in the room don't need to be reminded, but having a rare disease or taking care of someone with a rare disease day to day is a pretty crazy thing to do. It was for me for all those years with my son. And so the day-to-day is so busy and can become so overwhelming, just getting through our days, given the challenges that you face as patients with the symptoms, given the challenges you face as caregivers. So that in itself makes it hard for patients to reach out for help, and for newly diagnosed patients and families especially are very overwhelmed. So even if you have the time, then the next challenge is, where are the opportunities to receive support? There aren't many mental health resources available for patients and families affected by rare disease. There's issues with access, there are issues with cost, issues with stigma even within a family. And as a clinician, I can tell you that a lot of the first conversations I have with in therapy sessions, in a first therapy session, or when a patient joins a support group, people don't know how it works. How does this work, Dr. Al? I've never done this before. And some people don't take that step forward because of a lack of education about what mental health counseling means, or what it means to be in a support group. What does it look like? What is it about? And this is why every time I'm asked to speak online, especially, or at a conference, I'm often asked to give my permission to record something. I ask to be recorded so that people who aren't able to come or aren't inclined to come to something in person, or they can't because their lives are too crazy, has an opportunity to watch when they can watch, to access the content. And I hear from people that they're able to access content and get a little more comfortable with accessing mental health support when they have the opportunity to do it first a little bit at a distance. So that the unfamiliarity, in addition to the day-to-day craziness, I myself was able to watch content at 2 o'clock in the morning when I was my kid's night nurse. You know, there was no time to do it. So opportunities sometimes are challenging.
Malin, you want to react? You want to comment?
Yeah, there are many challenges with accessing mental health support. I think there are good examples. For example, in Sweden, we do have a counsellor in each rheumatological department that you can see. And it was actually one of the most important things for me was to see someone who specialized in these conditions and who knew what fatigue was. It was one of the most important things when I booked a time with her, and she asked me, so when are your functional hours? Because we need to book a time when you're functioning. And just hearing that was so relieving, massively important, to help you move on beyond the grief, beyond the devastation. So yeah, you definitely need to access it. It would be so nice if we could have it in all places, because it is so needed.
Tugba, I've got one question. That emotional aspect, mental health issues from the industry perspective, is it something you integrate in your research, in your development, when you think of clinical trials and things like that? Do you systematically maybe offer the patient entering a trial a psychologist visit, or is it something in pharma you are considering as part of the treatment or the trial, let's say?
Yeah, we usually do market research studies, focus groups with patients, qualitative studies to understand their mental well-being, to understand what their needs are. But in addition to that, we also trust in data with our partners, and we look at the reports, and we make sure we do our best to integrate those insights into our plans, like starting from the clinical trials. But there is sometimes gap, like I think what often stops awareness from becoming a real support is mostly distance. Like the idea of we're talking about the patients, but without the patients. So that is the challenge in the system usually, right? So awareness gives us facts, but not the feeling. So we should really listen and understand how it is really like to live with this dryness, pain, fatigue, because we cannot make any assumptions. So we should really work hand in hand together and make sure there is no miscommunication or misunderstanding. And so that's when the support can become real and bring some meaningful impact and value to the community.
Yes, thank you. That raises a point. Awareness does not necessarily need to action. So what concretely can we do as patient association, as patient federation? Geoffrey, what do you think? You talk about healthcare providers, insurance, something like that, payers, regulators, but what do you believe healthcare system or healthcare professional need to do to offer better support now, concretely, for people with children from your clinician side? What do you miss in your clinical practice to offer better support to us, clearly?
What I really miss is an early diagnosis. It's the main aim. I'm trying to follow this path, but it's nothing related to the healthcare providers here. We are late on Sjögren diagnosis generally. And don't forget that 2, 3 of the 4 even of the classification criteria are late consequences of the disease. So we are working hard on how to diagnose it very early, because more you wait, less the probability is to reverse the damages. But it's nothing related to the healthcare provider. It's on our side to do that. For the healthcare providers, what I would like to switch, but I think it's different from country to country, is probably give a better place to prevention instead of care when it's too late. I'm thinking here about tooth care, for example. It has a let's say, participation of the healthcare system when you have huge cavities and you need to change teeth. But it would be better to invest more on the prevention and doing things before having those cavities, because when they happened, it's probably too late. So changing the mind again about that. Consider subjective elements of the disease could be very nice. It's difficult, I know, but taking into account the fatigue, the neurological symptoms. But for doing that, I would be very honest to convince very objective people. We need to have objective ways to invest, measure that. So again, we need to work together to have clear parameters, biomarkers, parameters to follow from time to another time, because we are at a time area of objectivity, fortunately or unfortunately, I don't know, but we need to play with the same rules all together. So they are convinced by research data, pros, biomarkers, so we need to play the rule, and we need you all together to be highly invested in research, whatever the level is, but we need you. We can't do that alone on our side, because mice are nice, but they are still mice. They are not human beings with all the complexity. So we need you to participate to research, to continue. But to be optimistic, we are on the good way. When I started to work on Sjogren disease 15 years ago, we are clearly far away from that.
Yeah.
So it's on the good road. Let's continue this way. Would be my main message, probably continue the way we are now.
We have indeed the presentation. Do you mean that some tools are missing? Some evaluation tools, I mean, and from the patient perspective, we often say that from our point of view, there's a huge discrepancy between ESSDAI and ESSPRI, and for most of the patients, the ESSPRI doesn't relate, and I hope we have proven that again, that ESSPRI doesn't relate about our daily burden. Do you think we could move forward? And same question to Tugba in pharmaceutical field. Are you satisfied with the current tool you have to evaluate the disease? Do you think from your side it's okay? And maybe, I don't know, it's an open discussion from awareness to action. Everyone is aware about pain, fatigue, dryness, and other unmet needs. But now, what can we do? What can we do? Clearly.
Do you want to start, or do you want I start? Yeah. So the advantage of ESSPRI is that it's short to do, can be repeated. Don't forget that the ESSPRI is just a derivation of an old questionnaires with, if I remember well, 40 questions. That was very long to administrate, very long to evaluate. So the aim for the ESSPRI was to make it easier, and for doing a lot of clinical research, it's better when it's shorter, clearly, because if not, you cannot explore all the dimensions, the diversity. So maybe ESSPRI was a little bit too short, but we should find the nice way in between a very large questionnaire and the ESSPRI, which is too short, probably. But the good thing, and probably I will scoop a little bit the industry answer, it's a measurable answer. So you have numbers at the end. And it's easier to say, okay, we start from 8 and we go to 5. It's an answer. Saying it's from moderate to slightly moderate, unfortunately, it's very difficult to evaluate. So numbers are very important, objective measures of everything. But again, I think you are doing a great job now. It has changed a lot in the last 10 days, so continue this way. And we can improve everything all the time, but at a certain moment, we need to select things and keep them for a long time, because if we change the tools all the time, we cannot compare. So let's continue this way. It's a good one.
I totally agree. I couldn't agree more, actually. But there's always improvement, and it is a progress. And we need to have the patients at the table, though. So we cannot decide on a methodology where we don't hear from the patients. They should have a seat at the table during the discussions with the healthcare professionals to reflect their perspectives, so to make it resonate better with the community, and that they can have the discussion with the policy makers. So I think it is the key to have the patient a part of that chain where all decisions are made. So because they are the ones living this, and they can share their lived experience and contribute to the progress themselves.
Malin, do you want to add something from your perspective?
Oh. No, I'm back to the early identification, because when you approach the disease from a biological point of view, you always need to pair it with a clinical view. And I think pain, fatigue, and dryness, yes, it's short, it's easy, but it's also very simplified. We have different kinds of pain with different etiologies, and perhaps also 2 different diseases where one sort of pain is different from the other pain. Neuropathic pain is different from nociceptive or, other types of pain. And same with fatigue. We know far too little with fatigue, and I'm again thinking about the early identification. How is a person going to suspect Sjögren's if you turn up with fatigue? I'm sure there are different types of fatigue. It could be anything, but if you dig into it, are there differences like there are in pain? Can we help the clinicians out there? Because it's hard to get to the point where you're actually being tested, where you're actually being evaluated for Sjögren's.
Al, any comments?
I'm going to shift gears in terms of the patient's families' action. What actions can patients and families and communities take? In mental health, if you're depressed and you're feeling isolated and you're passive, it doesn't work very well. You don't feel good. But I tell patients all the time in my practice, if you're depressed, you want to fight it with action rather than passivity. In rare disease, once patients and families get their feet under them after a diagnosis, they often will turn to the community and ask, what can I do to help? And when a community like yours offers opportunities for patients and families to actively involve themselves, it helps patients to feel better and families to feel better. Because when my baby was diagnosed, they said, there's nothing you can do for your baby. There's no treatment. He's going to be here 2 years. So I turned my attention to, well, if I can't help my kid, what can I do? What could I do? And families like mine talk to leaders of organizations like this all the time. Say, what can I do? How can I get involved? So when communities, rare disease communities, provide opportunities, it not only helps the community to move forward, but it helps the patients and families to be part of that. And the spirit of this conversation is we're all in this together. When communities offer patients and families the opportunity to participate in events, conferences like this, advocacy, fundraising, when communities give opportunities for peers, newly diagnosed families to be together, for patients to be together, for caregivers to be together, like the group that met just today. The caregiver group here was wonderful. People feel empowered because they're actively connected with each other. And my own SMA community now, 30 years later, is like an extended family to me. I didn't want to be part of the club. None of us want to be part of this club, Sjögren's, any rare disease, but we're forced to be. And once we have energy and opportunities from our community, it becomes an extended family. When communities offer clinicians the opportunity to participate in training other clinicians, in being involved in research, registries, advisory boards, the clinicians also become, over a period of time, a lot of the groups I interact with are 30, 40 years old, the clinicians become part of the extended family. And then come, thankfully, the treatments come. And my son was born now, there are 3 approved treatments for the condition. The years have scientific progress has brought miraculous progress with many rare diseases. And when industry partners sponsor events like this, when you come to events like this, you join the community in events, then you're part of the extended family too. And ultimately, to have the effective treatments brings about a quality of life medical change that can be really extraordinary. But when industry partners also help meet unmet needs in ways beyond the treatment itself, it's very impactful and very meaningful. So communities, as communities develop, offer these opportunities for active participation. Active participation helps us all feel empowered, helps us all feel connected, helps us all feel together, and helps us all feel better in the face of adversity. And wherever I go, in my country and others, every time in a rare disease meeting like this, I see patients carry themselves with great grace and dignity, and communities lifting, community members lifting each other up and supporting each other. You meet a lot of really nice, open-hearted people when you come to stuff like this. And all of this feels better when we're actively involved.
Can I just, do we have time? Yeah?
Plenty.
Yeah. No, but to open up the opportunity for all of that, the basis is a diagnosis. And I think that we need to stop this business that we hear everywhere, that why would you want a diagnosis? The treatment is the same anyway. I hear that all over the place. A diagnosis is more than a guide as to what pill to give you. And if there is no pill, why would you need a diagnosis? That's like what they're saying to you. But treatment is, a diagnosis opens up your ability to access, to understand, to move on and move beyond, find management strategies, find connections and fellowship and resources. A diagnosis is so important, and it just really pains me when I hear, because it's online every single month. Why do you need a diagnosis? You have the treatment anyway. You've got your eye drops. You've got yourselves. We all need to change it. We need to advocate for that, because there are a few things that make me as angry as that, because there's so many non-pharmacological treatments. Treatment is not just a pill. It's everything else.
Yes, thank you, Malin. I think, well, yes, thank you. I think one of the words most said during that 30 minutes panel is that community. And you said it, Al said it, Tugba also insists on the necessity to work together. Geoffrey, of course, said, go on, continue. So I really think it's something really important. I would like you in the audience, do you have some comments, some remarks that you would like to share? Yeah, and specifically, if you have an idea of how to transform awareness into action, and what is the most needed? Do you agree with our panelists? What is the most needed from your perspective in your country? Fanny Louise, thank you.
That was too much for me to answer. I just want to add something to Malin's comment about diagnosis, because when I fought to be diagnosed, my stepmother says, oh, you should hope not to get a diagnosis. And I thought, okay, so it's better going around and thinking I'm a hypocrite. No, what is it called? Not a hypocrite, Hypochondriac. Yes. So that's supposed to be better than having a diagnosis. Yeah, Frey, sure.
May I comment?
Sure.
Yeah, I completely agree, and you said the truth. In my experience, having the right diagnosis changes a lot of things. Because generally, when a Sjögren patient doesn't meet the right clinician promptly, let's say, generally they listen to, oh, you know, it's nothing, it's just regular dryness, it's impossible, you have an immune disease, blah, 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 and take this on yourself and it will go away. And it can be long and desesperating, so it's very important to set the diagnosis, even if the treatment would just be teardrops and artificial saliva in the first time, but you know where you are, and you are not less considered as someone speaking out loud about subjective things. So to link that to my perspective as a clinician, maybe there is a job to do about the lip biopsy, because in many areas it's still considered as an invasive procedure, and many patients are afraid of that. So I'm trying to teach my students how to do correctly, but you know, alone on my end, I cannot teach to thousands of clinicians. So potentially to make the promotions of the good way to do it, and it's not an invasive procedure when it's done correctly. I know that some of you could have experimented very bad lip biopsies. I'm sure of that. But the constitution of Kensei network of clinicians able to do that correctly, stuff like that, recommendations could be a good idea, potentially, to leave the burden of having this biopsy and being able to have the right diagnosis at the right time. And early is better.
Any other comment in the attendees? Malin? No? Okay.
We're talking about fear of the lip biopsy. I know, Maria, one of the biggest emotions you found online was fear. And I think that we all have a responsibility when we go online to not frighten our fellow patients, because it's terrifying. Two things can happen when you go online. You read everybody's stories, and some are very sick, and you become terrified. And you go online, you ask, you know, how was your lip biopsy? And there's always someone who will write, I had so much trouble with it. I think we have a responsibility as patients to encourage each other and be positive. That's very important, to reduce that fear for newly diagnosed people. I had that fear, and a fellow patient actually said, can I ring you? And we talked for half an hour, and that made all the difference. She said, I've got a few resources. You can handle this. I think we need to pep each other. And yeah, just we take that all on us. Yeah?
Definitely, Malin.
Maybe one comment. That's why the patient advocacy groups exist. So it really is heartbreaking to hear like those comments, like you don't need a diagnosis, etc. That the patient's burden is minimized. So it is terrible to hear that, but it's also really hopeful to see that patients will have a choice, and the more patient communities work together, the stronger the voice will be. So it will be for the better future. And it is a privilege to be here, to learn from you, to understand all the insights. Thank you very much.
Thank you, Tugba, for your kind words. I think that what we can say, and what is perfectly clear, is that action doesn't belong to one group alone. Tugba just said it again. it's the combination of care, mental health, innovation, and lived experience that will really make a difference. And as we close this conversation, I would like to thank you, our panelists, for your insight. Thank you all for being part of this discussion, for being with us during this conference. What I would like to say as well is that awareness is not an end point. Awareness that we are all doing is the starting point. The real challenge and the real opportunity is to take that awareness and turn it into action. Our slogan, don't know who says that in English, is at Sjögren Europe, together we are stronger. And I really think that we are all of us, part of the kind of bricks in the bridge we are building together. At least that's our goal. We work hard with all the stakeholders, including health authorities and payers regulator. So thank you all. I get back. Thank you all, and let's continue this journey together. Thank you.
So, that's the end. And as we come to the end of this inspiring gathering, I would like again to thank you, all of you, and each one and every one of you, for being part of our conference, for your time, your insight, and your passions. Over these 2 days, we have shared stories of strength and purpose, explored the latest sciences, and reimagined what patients' partnership can truly mean. We have spoken about bugs, gaps in awareness, in access, in research, but we also have been seeing that if we are together, we are closing them. The message from Larnaca, from our Congress, is clear. Collaboration is not optional. It is essential. From patients and clinicians to researchers, policymakers and industry partners, we all have a role to play in shaping a better life and a better future for people living with Sjögren. Let us leave this conference not only with new knowledge, but with renewed determination to turn awareness into action, empathy into advocacy, and science into meaningful change. Thank you all again for being part of this journey, for believing in this mission, for our mission at Sjögren's Europe, and for making Sjögren's Europe stronger than ever. And we are stronger, and this is on to you. Thank you very much. Together we can do a lot. Last, let's announce that, don't forget that we have our General Assembly and elections early November. You have all received the first announcement. And our new and conference meeting, whatever you like, we can tell, in 2026, will be in Rome. Just being at the end of November, beginning of December, where Nikki, which is the project leader of our conference, yeah.
Wonderful organization.
I would like to thank again Nikki for his and her help. Without her organization, strictly professional, we're not doing that very good, very professional and organized good. I would like to thank also my colleagues in my company that help Nikki and me to organize that. Thank you, Amalia. Thank you, Artemis. And last, we are going to help, and please, a great clap for our IT control back there, because without them, we're not having all that audiovisual. Thank you very much, guys. Last but not least, all our supporters. Amgen, sorry, I have to remember that. Amgen, Novartis, J&J, and Bristol Myers Squibb. Thank you, all of you, and we're very happy and glad to have you with us. The conference is ended, but 4 o'clock, please be in the lobby. We have our last networking social gathering, okay, to see Larnaca, and then to have our dinner in Larnaca, the last dinner in Larnaca. Thank you again, all of us, and all of you. Thank you.